Okay, good morning, ladies and gentlemen. I'd like to thank the course organizers for inviting me to speak today. So for the next 20 minutes, we're going to go through a whirlwind tour of autoimmune and cholestatic liver disease. These are the three diseases that we're going to be speaking about, the first being primary cholangitis. So getting right to it. So PBC, we all know that in 2015, the name changed from cirrhosis to cholangitis, but arose by any other name is just as sweet. It is the most common autoimmune liver disease, and 90% who are affected are women, and the median age at diagnosis is 50s. So the prevalence is 40 to 400 per a million, but that means that over the age of 40, 1 in 1,000 women have PBC. And the hallmark of this disease is a positive anti-mitochondrial antibody. So in terms of symptoms, most people are asymptomatic. We have primary care doctors are checking liver tests annually, and the first sign is an isolated elevation in alkaline phosphatase. Symptoms, if they are present, usually include pruritus and fatigue, which are very nonspecific. Don't forget to ask that 50% of women with PBC also have a concomitant autoimmune disease, so you want to ask about hypothyroidism, so much so that I actually check a TSH in women every 2 years with PBC. Sicca syndrome, scleroderma, rheumatoid arthritis, lupus, and celiac disease. You also want to make sure you exclude a non-liver source of elevated alkaline phosphatase, the most common being bone, and of course biliary obstruction. So right upper quadrant ultrasound is always a good thing to get when you're considering this diagnosis. And for the diagnostic criteria, you only need to meet 2 of the 3 following. 1, an elevated alkaline phosphatase greater than 1.5 times the upper limit of normal. A positive AMA of greater than or equal to 1 to 40. And for those of you who are wondering, 1 to 40 is no better than 1 to 160 or 1 to 320. Positive is positive, it's categorical. And of course, liver biopsy. So let's think about diagnosis on liver biopsy. This is a classic picture that you're going to all see on your GI boards. But essentially, you see a florid duct lesion. So I have a big arrow pointing to the bile duct epithelium, which consists of cuboidal cells, and see how it's not perfectly circular and round. So that's the definition of the disruption of the bile duct. You also have crazy inflammation going on and injury to the bile duct epithelium. And you can also occasionally see granulomas in addition to ductopenia. So let's say that you have someone with an elevated alkaline phosphatase, but the AMA is negative, but you're actually quite convinced that this is actually PBC. At that point, you would actually do a liver biopsy, and this is kind of when you most often use a liver biopsy in this disease. And of course, an AMA negative PBC is essentially called in the old literature terminology autoimmune cholangiopathy, where you have a negative AMA, an elevated alkaline phosphatase, PBC on biopsy, and most often you see a positive ANA in this situation. So I think it's important to understand that PBC, there are clinical variants to this disease. We've already talked about AMA negative PBC, which essentially looks like AMA positive PBC, but there are 2 other variants that I want you to understand. The first being the PBC autoimmune hepatitis overlap syndrome, and there you have components of both autoimmune hepatitis and PBC. So clearly you can get elevated AST and ALT from an elevated alkaline phosphatase alone, but if it's greater than 5 times the upper limit of normal, you should be thinking about a concomitant hepatocyte process, an elevated IgG, and a smooth muscle antibody. You have to do a liver biopsy in this situation, and you have features of both autoimmune hepatitis and PBC. There's also another kind called a premature ductopenic variant, and this is a little bit more rare and more often seen in younger women. And this has a rapid, severe cholestatic pattern that quickly goes to cirrhosis. So in terms of treatment, so the first line is UDCA, and we do that at 13 to 15 mg per kg. And this actually approved FDA approval as an orphan drug in 1997, and it's still the stalwart of treatment. We know that PBC improves liver tests. We know that it delays progression of fibrosis, and it also decreases the need for liver transplantation and death. You also want to treat the symptoms, pruritus being the most difficult, and we can use cholestyramine, make sure you make that separate from your other medications, sertraline, naltrexone, and rifampin. I also get a DEXA scan on all my patients because the rate of metabolic bone disease is very common in this population, and I always advise them to take calcium 15 milligrams per day and vitamin D 800 IUs per day. So the funny thing is 40% of patients have an inadequate response to ursodiol. And when we say inadequate response, we usually mean that they're unable to tolerate UDCA, meaning they have GI upset, or they have an incomplete response to UDCA, meaning that they're taking the medication, they're tolerating the medication, but their alkaline phosphatase is not going down. And that's important because when you have diseases like PBC and PSC who have very prolonged time courses, you have to have an alternative biomarker or something to follow so you know that you're doing something for the patient. So in 2016, obeticholic acid came out as a treatment for PBC. And obeticholic acid actually has many actions, but most simply, it's a regulator of genes involved in bile acid synthesis. So this is the study that came out in the New England Journal of Medicine. Basically, there were 3 groups: a placebo group, a group of patients who got 5 milligrams of obeticholic acid, and a second group that got 10 milligrams of obeticholic acid. And basically, you see that the starting alkaline phosphatase in this group was about 320. This study ran for about 12 months. It was randomized. It was blinded. And we see that the people who got obeticholic acid had an improvement. 46% met the primary endpoint, which is a reduction in the alkaline phosphatase by 1.67 times upper limit of normal. And that 1.67 actually came from the Toronto criteria on improvement in alkaline phosphatase, who led to better prognosis. 93% of the patients in this study were also on ursodiol, and 90% were also women. So when you think about obeticholic acid, you want to remember that these are for non-cirrhotic or Child-Pugh Class A patients. The starting dose is 5 milligrams per day and not 10 because of the pruritus that was associated with this medication. And after 3 months, you up-titrate as tolerated up to 10 milligrams. And again, the main side effect was itching, and it was dose-dependent. Now, we all know that itching is part of the disease, so how much of it is from the disease and how much of it is from the medication. And it was significant, with 19% in the 5 milligram arm and 7% in placebo. So I'm sure you're aware that last month in February of 2018, there was post-marketing safety data that showed that there was hepatic decompensation and failure in incorrectly dosed PBC patients with Child-Pugh B and C decompensated cirrhosis. So the important takeaway point from this is that you have to be very careful in giving this medication to people who are Child-Pugh B or C cirrhosis, that they should only be on 5 milligrams per week, not 5 milligrams per day. And you have to monitor these patients very closely following their liver tests while they're on treatment. And if you have patients on this treatment, you should ask yourself to reevaluate and see the patients you have on this medication to make sure that there are no negative side effects. So this is something that came up at AASLD this year. I noticed that there were more and more abstracts about the role of fibrates in treatment of PBC. So this is currently off-label in the United States, and the most well-studied fibrate is benzafibrate, which is not available in the US. It is not FDA approved. However, it is available in Europe, and there are actually randomized studies going on right now in Europe. In the United States, fenofibrate is the one that we have access to here, and we use a dose of anywhere from 100 milligrams per day. However, you have to be very careful because it has been associated with increased transaminases, CPK and CM creatinine. So this is something also that is currently being studied in PBC. Okay, so despite all that we do, 10% will still progress to liver transplant, and the outcomes are very good. Survival is 90% at 1 year and 83% at 5 years post-liver transplant. And unfortunately, those 60% recur after transplant at 15 years. So this is the population that I do keep patients on ursodiol after transplant. So moving on to autoimmune hepatitis. So this is a chronic inflammatory condition, again, mostly impacting women. The prevalence is 15 to 25 cases per 100,000, and both the incidence and the prevalence is rising with the bimodal age distribution, affecting people in puberty and 40 to 60 years of age. Now, autoimmune hepatitis in a nutshell, we want to think about antibodies, we want to think about hypergammaglobulinemia, we want to think about interphase hepatitis on biopsy, and again, in association with other autoimmune diseases. But the hallmark really is that this disease responds to prednisone. So the presentation is so challenging at times, but 30% present with cirrhosis, meaning that they've had asymptomatic abnormalities in liver tests for many, many years. And 70% are very nonspecific or asymptomatic, meaning fatigue, malaise, anorexia, right upper quadrant pain, nausea, itching, and arthralgias. For laboratory findings, clearly this is a hepatocellular pattern of injury, so the AST and ALT are elevated, but that does not always correspond to the severity of the disease, and that's important when we talk about management later. These liver tests are fluctuating, so if you trend someone's liver test and they were a little high in 2014, normalized in 2015, up again in 2016, ding, ding, ding. And of course, the autoantibodies, the hallmark being ANA and smooth muscle. And I've also included here LKM and SLA, which is actually more commonly seen in the pediatric population with autoimmune hepatitis. So this is another classic board question on liver biopsy. You see interface hepatitis, you see plasma cells, and you see rosette. So very different than the picture I showed you prior for cholestatic primary biliary cholangitis. So there is an international autoimmune hepatitis group simplified criteria, and this is a little score that you use. I never actually document this in my documentation, but it kind of helps you keep in mind what's important when you think about or make the diagnosis of autoimmune hepatitis, meaning the IgG greater than 1.1 times the upper limit of normal, the antibodies, the histology. So every other liver disease, whether it's hepatitis C or B, we're moving away from liver biopsy, but autoimmune hepatitis is the one liver disease that's going to keep liver biopsy in business. Very, very important. So when we talk about autoimmune hepatitis treatment, this is probably the hardest and the most hardest slide to go over, but essentially there's two approaches, and this is based on both EASL, which is the European guidelines, and AASLD, which is the American guidelines. And essentially, you either start with prednisone or you give prednisone plus azathioprine. The Europeans like to give higher doses of prednisone, starting at 60 milligrams a day, and they like to keep people on prednisone for a long time, so on average about 1.5 years. Unfortunately, there are significant side effects with prednisone, which are listed below. And also, you also want to think about when do you do dual therapy and when do you just do prednisone? So I always say that the patient's jaundice, that's quite a robust immune reaction. So I never start azathioprine and prednisone in a patient who's jaundiced. But if the bilirubin is normal and it's just simple elevation in AST and ALT, I will consider dual therapy. So in terms of endpoint, so a long time ago, we used to say that if we got your liver test, AST and ALT, to greater than 2 times the upper limit of normal, we did a really good job. However, we recently found out that the goal for treatment should actually be complete normalization of AST and ALT. And we know this because people who normalize their AST and ALT, 4% will have histological progression to fibrosis, whereas people who remain above that have a 55% chance of histologic progression. So it's very important that that is our new goal. Of course, there's treatment failure where you have worsening labs and symptoms, that they get more decompensated in their liver disease. And of course, incomplete response where you have some improvement in labs, but not worsening. So in terms of treatment withdrawal, it is very controversial. There's a high risk of relapse if you stop treatment. You know, patients don't want to be on long-term medications, and they say, well, my liver tests are normal, why am I still on treatment? EASL goes as far as to say that you should be on treatment for at least 3 years with normal AST and ALT for at least 2 years before you even think about stopping treatment. And we always recommend a liver biopsy prior to withdrawal because, again, we know that histologic progression lags behind the normalization. And also we want to get a sense of staging and prognosis. So what degree of fibrosis do they have? Is it stage 0, 1, 2, 3, or 4? And how does the hepatocytes look on biopsy? So it all sounds pretty easy, right? Prednisone, azathioprine, but I find that every single patient who I treat for autoimmune hepatitis is very unique, their presentation is unique, and their response is unique. So when we think about second-line treatment for autoimmune hepatitis, it's usually in the setting of, hey, it's not working, or they're not able to tolerate the treatment due to side effects. So I touched upon prednisone before, but let's get a little bit deeper into it. So prednisone-related side effects, 80% will have facial rounding, weight gain, hirsutism, glucose intolerance, and emotional lability. All the women love all of those things. 13% will have osteopenia, diabetes, and psychosis, which is actually treatment ending. And of course, the rare ones are opportunistic infections. Azathioprine isn't completely benign either. 46% will have hematologic cytopenias, meaning decrease in platelets, WBC, and hemoglobin, and 5% will have nausea, rash, fever, and arthralgias. So for second-line treatment, we talk about MMF is the most common when we talk about 500 milligrams POBID. Remember, that's for people who actually responded to azathioprine but couldn't tolerate it due to its side effects. But of course, this is teratogenic, so you really want to avoid this in the young women with autoimmune hepatitis. That's not going to be very helpful. The next one is budesonide, which is actually not on formulary here in the United States, so it's actually a very hard drug to get. But if you have a patient who is unable to tolerate prednisone due to side effects, this is actually a great medication to consider. But you have to remember that you cannot use it in cirrhosis, and long-term studies are still pending. So finally, we're going to talk about primary sclerosing cholangitis. So we know this is a chronic cholestatic liver disease that affects the intra and extrahepatic biliary tree. We have large duct and small duct PSC. Large duct you can see on MRCP. Small duct, you have a normal MRCP, so you need a liver biopsy. Variable rates to progression and biliary cirrhosis. The prevalence is about 16 per 100,000, mostly men. So finally, we have mostly men, not women, 30 to 40 years of age, and a very strong association with IBD. And the phenotype of IBD is actually more right-sided inflammation, rectal sparing. And all patients with PSC must undergo colonoscopy with biopsies to rule out IBD at this diagnosis. The prognosis is terrible. We see that most people will need a liver transplant at between 12 and 22 years after diagnosis. But the symptoms are pretty unnefarious, meaning they're mostly asymptomatic to pruritus and cholangitis. They have the hallmark elevated alkaline phosphatase, and 10% have a high IgG4, and that's not to be confused with IgG4-related cholangiopathy, but a subset have elevated IgG4 who are known to have a more aggressive disease. So in terms of diagnosis, so we talked about how it strictures on cholangiogram. So the MRCP is the preferred one because it's cost-effective, it's accurate, it's non-invasive, there's no radiation. However, the ERCP, which is the prior gold standard, has better sensitivity for subtle changes in the distal bile ducts, and of course the simultaneous therapeutic intervention is possible. And a liver biopsy is not necessary here unless you're thinking small duct PSC or overlap autoimmune hepatitis, which you actually more see in the pediatric population than in adults. When you think about this diagnosis, you don't want to miss anything, so you always think about IgG4-related sclerosing cholangitis on the differential, including recurrent choledocholithiasis, cancer, ischemic cholangitis, portobilopathy, and recurrent pyogenic cholangitis. In terms of management, there is no medical therapy. Now, UDCA is pretty controversial. We've done many studies on this. We know that high dose is bad, so that's 25 to 30 mg per kg, more treatment failure, death, liver transplant, bleeding. 17 to 23 mg per kg, your liver tests improve, and there's a trend toward improved survival. And then low-dose UDCA, which is the PBC dose, liver tests improve, but we know that there's no changes in survival. So I say 20 mg per kg is the dose that I put on for PSC, and see if that will help their alkaline phosphatase. So again, we do not recommend high-dose UDCA. If the alkaline phosphatase is elevated, I would consider UDCA at 20 mg per kg, although there's no well-controlled studies. You want to reevaluate every 6 months to see if it's working, because if it's not working, then you should stop. And of course, there's a case-by-case assessment. So blanket statements are really hard in this group or in any of the diseases that we talked about today. So in terms of surveillance, we're always worried about cancer. So expert opinion states you should get imaging every 6 to 12 months. I vote for 12 months. Serum CA-19-9 every 12 months. But again, we all know the limitations of this test, especially in people who have obstruction or cholangitis. Cholecystectomy if you find gallbladder polyps greater than 8 millimeters, because there is an increased risk of gallbladder cancer in this cohort. And an annual colonoscopy if they have IBD. So in terms of complications, I rely on my interventional colleagues a lot for this. 50% will develop dominant strictures. You want to make sure, oh dear, I hope this is not cancer, because 25% is malignant. You do burst cytology in fish to assess this. And of course, there's endoscopic therapy, which really is balloon dilation. If there's really bad stricture, you can consider short-term stenting, short-term meaning less than 2 weeks, because you really don't want to leave that around, as it can cause more problems. Bacterial cholangitis, I do have some patients on cyclical antibiotics if they've had multiple episodes of cholangitis, Cipro being my go-to. And of course, decompression and the malignancy surveillance guidelines that we discussed on the prior slide. So PSD and liver transplant is the definitive treatment. You can get MELD exception for this, just like you can get for other diseases. Oftentimes, because the MELD is not a great, it doesn't really capture patients how sick they are with cholestatic liver disease. And you can get MELD exception if you have more than 2 episodes of bacterial cholangitis or greater than 1 episode of sepsis. And UCLA is the only program in California who has a transplant protocol for patients with cholangiocarcinoma. Their 5-year survival is great, but you do see a recurrence of 20% at 5 years. These are the references that I used to obtain all the information, and thank you very much.